Hello, welcome everyone to ER Skill Lab. I'm Dr. Farooq, specialist in emergency medicine working in UK. Today we're going to discuss on some common mistakes in cardiac arrest. We see cardiac arrest every day, isn't it? Anyone working in emergency medicine or any critical care setting has to have a clear understanding on what's going on. And are you ready? Are we ready as a team to handle cardiac arrest? So let's break it down, okay? The first thing I notice in cardiac arrest, I'm talking in the context of my past experience in Bangladesh. So let's assume we're in a country where emergency medicine is not a specialty yet, or you're working in a remote area where people are not well trained in BLS, ACLS, and that's how it goes. So let's see what happened first. The first thing happened in cardiac arrest, the worst thing I would say, is this: not to start CPR immediately. Is not to start. The issue is, I've seen it many times. Nurses, PCAs, other healthcare providers, they shout for the doctors, doctor, doctor, there is an cardiac arrest. And then what's happening? Have you started CPR? No. So don't wait a doctor to come to start chest compression. That's the most common mistake. That should not happen anywhere in Bangladesh or anywhere in the world. So if it is a cardiac arrest, start CPR. The question is why this is still happening. Train everyone. Train everyone in your emergency department, including nurses, doctors, patient care people, receptionist, even the doorman, I assume, and someone is cleaning the floor. Everybody who is physically present in the emergency department, teach them how to diagnose a cardiac arrest. What's the difference between an unconscious patient and a cardiac arrest? And once they know it, if you train them enough, good, and tell them to start CPR anyway. There is no harm starting a CPR, but there is a harm not to start. So this should never happen. Okay. Second one. And before I go to the second one, is the patient is unresponsive. How do you know this is a cardiac arrest? Check the pulse, the carotid pulse. Try to shake and waking up. Check the pulse. That's the technique. Carotid pulse. If the patient is unconscious, you can't wake him up. Pulse is not there. It's cardiac arrest until proven otherwise. Start CPR. Okay. Second is, well, somebody started CPR, then like 3 people came to the bed, but everyone is confused what is next. It's big confusion. Big confusion on what next. Well, I sometimes call it a third step error. Sometimes a third step because, well, if someone is just doing chest compression, the next person available should move on to the airway to have a bag valve mask ventilation, put a oropharyngeal tube, basic bagging to confirm there is a chest rise and fall. That needs a bit training as well. So to eliminate the confusion, the question is, well, let's see. This is the most common mistake that I heard during this early stages of CPR. So someone is doing chest compression, the next is, okay, airway maintenance. What is the third step? If there's a third person there, what he or she should do? I also called it a third step error. This, I've heard this so many times. It happens most of the time in most of the places, and it's still happening until we figure this out and tell and teach people to avoid it. The third step is not an IV cannula, is not doing something else. The third step is not going to be DC shock, no. The third step obviously is to attach the cardiac defibrillator monitor to check the rhythm. This is very important, and I'll come back to this later. This is why rhythm. Why to check heart rhythm. Why this is really important. Okay, so chest compression, airway, and attached to the monitor with defibrillator pads. If we have, we don't, in Bangladesh, I don't think that we have a sticky pad, but then put some cardiac monitoring, at least 3 leads, to see the monitoring, to see the rhythm and the monitor. That is the third person should do. Well, it's very important. The question is why? Why this is very important? To answer this, I would ask the question. So whenever someone tell me, one of the nurses in one of the teaching session, why this is important, I ask this question back to everyone. It's very important. What is the difference between, what is the line between BLS and ACLS? When do we start ACLS? When the BLS stops and ACLS starts? That's an important question. So question of BLS versus ACLS. When does basic life support stops and ACLS starts? Well, that's where it comes in. You need to check the rhythm. If there's a rhythm is shockable, give shock. Once you give in shocks, and then we go on to this ACLS pathway. If it is non-shockable, ACLS pathway. It's very important to know that to be able to complete BLS, we need to see the rhythm. That is very important even before putting an IV cannula in. If you have an extra person, yes, one person is attaching the monitor, other person doing the IV lines, that's fine. But you cannot skip the priority of seeing the rhythm before you put the cannula in. Okay? Third step is medication error. So I've been telling this all the time, and I've already had a post in there in EMBD. This is one of the most high level errors. Even this is the error was there since for a long time in Bangladesh. I think it's still in there. The dose of adrenaline, and it is surprising that we don't have the correct dose of adrenaline in most of the hospitals. It's a pre-filled syringe, 10 ml of 1 in 10,000 adrenaline. And the adrenaline we have in ED in Bangladesh is 1 ml of 1 in 1,000 dilation, which is 10 times concentrated dose to be used in cardiac arrest. And if you use those doses in IV, this is fatal. We cannot use those doses anymore. So if you don't have this 10 ml 1 in 10,000 dilution, and you only have 1 ml of 1 in 1000, add 0.9 ml of normal saline and dilute it into 10 ml. That becomes at 1 in 10,000. Give it to during the cardiac arrest every 3 to 5 minutes. Okay, so the adrenaline is next. Adrenaline dose. And why this was so important here, because when I found out, and I actually made a complaint to the hospital authority that, well, I think we need to change the adrenaline dose during cardiac arrest, and then I was being called by the cardiologist and ITU, the whole two departments, in a seminar room. I'm the only person defending the dose. The rest are against me. So it's been there as a wrong practice for a long time. Everybody, including ITU and cardiologists, been using it for a while. And then that's why they didn't like what I said. The evidence to this obviously is American Heart Association or UK Resuscitation Council. If and that is still a problem in your hospital, you need to speak to someone, print out the guidelines and speak to someone. This needs to be changed. And I believe after this lecture, none of this, if you're watching me, and if I can get in touch with you in future, I want to make sure that you change your practice in your hospital from today, from now. This is knowledge. You cannot do harm to a patient. Not knowing is a harm. Anyway, the fourth issue during this cardiac arrest is, might say, leadership. By the time you're starting these medications, there may be 5-10 people, cardiologists, consultants around this, and everyone's saying, okay, give 2 adrenals, give 2 atropines, 5 adrenalines, like blah blah blah, do this, do that, and then there is no leader. Everybody is leader. There's a problem with leadership. Nobody, it doesn't matter who is the consultant or who is the specialist, there should be one pre-designated team leader. This is, without this leadership, it's not going to be effective code blue cardiac arrest situation anymore. And this decision needs to be made prior to the cardiac arrest. So in every day, every shift, in every hospital, there should be a meeting or there should be a rotation, like a documentation. If any cardiac arrest happens today, who is going to be the team leader? It doesn't matter. It doesn't have to be a cardiologist. In cardiac arrest scenario, to manage ACLS, BLS, we do not need cardiologist. Why? What the cardiologist would make any difference here to run this code? No. You do not need a cardiologist to become a team leader. You do not need an ITU consultant to become a team. You can be a team leader. As an emergency physician, you are good enough. If you're well trained, perfect. This needs to be changed. In UK, cardiologists never show up in emergency department for a cardiac arrest. No. ITU anesthesia, they might sometimes show up. If you're failed to have a difficult intubation, yes, you might need anesthesia, but they're not the team leaders. Emergency doctors will be the team leaders. Leadership goes into ED, should go to ED if they're well trained. Good. What's number next? Well, the other thing is, I would say, airway. Why airway? Because we just put an ambu bagging, and we don't even care if there is enough chest rise or fall. And putting an oropharyngeal tube bagging, and we don't actually care to see if there is a chest rise or fall, or if you're having difficulty breathing. So it's very important that we focus on this airway management, because even if your CPR is successful, there may be permanent brain damage. The heart can come back after a good CPR, and ACLS, heart can come back, can have ROSC, return of spontaneous circulation, ROSC. Even after ROSC, patient can be brain dead because of hypoxia. This is one of the most important part of that can make a difference. This is one of the most important and time-sensitive issue that we need to focus on during all these scenarios of cardiac arrest. Minimize interruption of chest compression. If you interrupt more than 10 seconds, this is not good for brain. Anesthesia, or you are trying to intubate and you cannot see the vocal cord, blah blah, and then it's more than 10 seconds, back off. Start CPR, do the ambubex, and then try again the next cycle. Okay? Do not intercept. One of the effect of good chest compression is blood circulation and oxygen to the brain. So less interruption of airway is one of the key to prevent long-term disability of brain damage. Do not take too much time off on there. So what's the next? The other thing is in cardiac arrest. So let's say we're having good team, we have intubation done, chest compression is well done, everything is well done. What next? Well, sometimes it's prolonged cardiac arrest and we don't know why this is causing it. We need to get other things done. We need to do other things done to diagnose it. What other things? Other than just checking the rhythms. It could be PEA, pulseless electrical activity. What are the reversible causes of cardiac arrest? So there's like mnemonics of 4H and 4T. And we need to do certain things to eliminate those differentials. Ideally, we need an ABG because we want to see the electrolytes. We need an echo. It's something new. They call it FEEL, Focused Echo and Emergency Life Support, which can be done within 10 seconds while we are checking the pulse. And there is special training for that, of course. But this quick bedside echo could rule out huge pulmonary embolism, pericardial effusion, even pneumothorax. So we need to keep other things going while we are doing these cycles of chest compression following ACLS. And what are the last thing I would like to say in common mistakes? So I think this should come at the top. Even this, I'm saying at the last, it's like preparation. Are you prepared to handle cardiac arrest even before it starts, before you start your shift or before you start working? Preparation is the key. For the nursing point of view, how many nurses, how many doctors are there? You actually need 1 or 2 doctors and most of the nursing staff. So what I tend to start at United Hospital, we call it silent CPR book. It's like a kata, it's a binding book. So every shift nurses come in, they put their names in, who will be willing to be in the cardiac arrest and who is going to be doing what. So every shift we have an organized preparation of nursing team in cardiac arrest. Is very, very helpful. It eliminates all the confusions and everything. So preparation is one of the most important in all of this to begin with. Knowledge, preparation, and avoiding the mistakes. So Here we go. Thanks for watching. I